a good thing to come into a class with all forms of this thing. Please put your name and get serious, or you are out of this place. No, I'm not joking here. We are going to continue our studies today by looking at the various types of study design. Those of you who are disturbing me by not putting your name, I will remove you. And if you disturb me much and I'm out, I'm actually very tired from work. You are all adults and I expect us to behave like adults. I don't want to chase anybody around anybody like a kindergarten. You can't come into a class and you put one type of sign as you are this. If you are here, we know you are here. If you don't want to be serious with us, no problem. It's not anywhere. You are not obliged to be so, right? To do so, okay? So please, this is the last time I'm saying that. This is the last time I don't have to waste my time with that at all. All right. So today we are going to study epidemiological study design. We'll start with descriptive studies. I missed it the last time. And tomorrow we'll continue with it. So please, I want you to pay attention very well because tomorrow is Tuesday, right? Yeah. Tomorrow is Tuesday. So let me do as much as I can today. Try to combine what I missed the last time, and that. So please, wow. Just bear with me. Let me get my slides. All right, so we're going to look at overview of epidemiological, or if you like, call it epidemiologic study designs. Then we are going to focus on descriptive studies and ecological studies, after which we'll try and look at analytical and experimental studies. Then tomorrow, briefly go through aspect of study design like sampling methods and all that. Okay, that's tomorrow. And let's see how I can combine all that because the other half will be done by someone else. But let me see how far I can go. Right, so I will start by sharing my slides. Okay. All right. Here we have it. So we're going to look at study designs. And by study design, I mean the ways we scientifically design a research study before we carry it out. There are various ways, and these study designs actually determine the strength of evidence of every research. Some study designs are weak, other study designs are much stronger. Some study designs are weak, other study designs are far much stronger. So when we look at hierarchy of research studies, we see that every research, all researches are not the same. They are all not the same. And the difference is based on the strength of evidence that research is capable of putting out there. If the strength of evidence is weak, if the study design is weak, then the strength of evidence will be weak. If the study design is very strong, the strength of evidence will be strong. I believe when we started earlier on, we looked at the hierarchy of research studies. It tells us about the ranking. So from the lowest rungs of the ladder going up, we have things like people's opinion about issues, then things like case reports and the rest of them. And at the highest level, where we have experimental studies. So we're going to look at the various study designs that exist. That's the overview I'm going to talk about now. So this is the type of study design, as you can see. Take note that there are all studies as a whole. Generally, research studies are grouped into two or are classified into two. You can't find this on the note. I've not written them down. They are classified into two groups. And these groups are either quantitative research studies or qualitative research studies. So the aspect I am going to be talking about is quantitative research studies. By tomorrow or so, the other half of tomorrow, when Dr. Bobona will come, I just, in fact, it's even clashing with her assignment. Maybe I will get it for another person, perhaps, is the one we call the qualitative research methods. Maybe because I think she's having another class altogether. So quantitative research methods are those research methods that have to do with quantities, just as the name suggests, where we are counting numbers, quantities. While qualitative research is simply about narrations, there are no data involved in qualitative. So it's about just narration. Maybe you grant an interview to seek somebody's opinion about something, he discusses it with you. Those are qualitative. But quantitative, you design a questionnaire, administer the questionnaire, analyze the questionnaire to produce a result, and categorize the responses in quantities. So percent said so percent not say so, and things like that. Or so percent practices this, so percent does not practice this. That is quantitative, because quantities are, are involved. Enumeration is involved. Data analysis, quantities are involved. So we're looking at that aspect. Now, all quantitative studies are grouped into two types. They are either observational or they are experimental. They are either observational or experimental, right? The observational or experimental. So the observational studies are further grouped, just as you can see here, into two. And the basis of grouping them into two is if they have a control group or not. A control group is a comparison group. If we are going to compare two sides, for instance, if we want to see academic performance of students who, assuming we have a hypothesis to say that illicit drug use, just assume, for example, illicit drug use does not affect academic performance. Assuming there is a notion or hypothesis like that. So we now want to see whether, if truly illicit drug use among students affect academic performance or not. Maybe we don't know if it does. So now we're looking at what? Two groups. One group is those that use illicit drug, and the other group, the comparison group or the control group, they are the same thing, just synonyms. The comparison group or the control group is the group that is not using illicit drug. Now we follow them, or we look at them and compare their academic performance. When we compare their academic performance, then we can say with certainty if truly illicit drug use does affect academic performance or not. If the academic performance of the two groups are similar, then we can quickly run to the conclusion that, even though these people are using drugs, the academic performance is not different from the group that is not using it. We had a group we compared with. So if an observational study has a comparative group or a comparison group or a control group, as I said, they're just synonyms. Such observational study is called analytical study if there is presence of a comparison group. However, if an observational study does not have a comparison group, such observational study is called a descriptive study. So observational studies can be two types, the descriptive and analytical. That's what it is. So today, we're looking at the descriptive and we're going to look at analytical. Okay? Also, and let's see how it is possible. If it is possible, we look at the other group, experimental or interventional. So that is how we group them. Then when we now look at the descriptive studies, we now have examples of descriptive studies, which are case reports. You can see them on the screen. Case series reports, cross-sectional studies, ecological studies, right? Then we can also have, in some books you read, you can also have comparative studies there. That is cross-sectional comparative studies as well in this group. Then when you go to the group that has comparison group, the arm that has comparison or control groups, we have case control studies, cohort studies, and historical cohort studies. Case control studies, cohort studies, and historical cohort studies. Case control studies, cohort studies can be named differently. We can have prospective cohort studies and retrospective cohort studies. The prospective cohort studies we have now, as you can see, the cohort studies you have, you can see here, is actually prospective cohort studies. It means you are looking into the future, prospective, into the future. Then the other one, this one written historical cohort study. From the word historical means there is something about history. And history is usually things that occurred in the past. In this case, the that historical cohort study is called retrospective cohort. So there are synonyms. The cohort study you are seeing here is prospective cohort studies. The historical cohort study, another name for it is retrospective cohort studies. So if you look at it, cohort studies are two types: prospective cohort and retrospective cohort, which implies in this slide cohort studies and historical cohorts. Okay, so now you can see these studies and the synonyms or alternative names or alternate names. Okay, like cross-sectional studies, they are also called prevalence studies. Ecological studies there you saw in the among the descriptive are also called correlational studies because we determine correlation, a relationship, and we use certain test statistics to determine them. Then among the analytical studies, we have case control studies. We call it, another name for case control studies is case reference studies. Now, this retrospective you see in case control study is not because it is a retrospective cohort, no. It is because case control studies is also retrospective by the method of its conduct. We are also looking into history back, that is case control. Then the cohort, as I told you, cohort, you have prospective, you can call it prospective cohort or you call it cohort. You are following up, prospective, following up into the future. While retrospective cohort or historical cohort, you are relating from past history. Then we can also have the type we call nested case control studies. Nested studies are what we call studies in studies. Studies in studies. And these studies, for instance, you want to carry out a study broadly. And first of all, within that study framework, you carried out another smaller study with which you apply in the general study. But I usually don't teach it because it brings a lot of confusion. And when you are coming up, taking something it's good to go bit by bit. I realize that at undergraduate level, most of you will not have come across this. Some would have come across, but we don't emphasize much about this at undergraduate level. Most times the research you do at undergraduate level are usually this type of very wishy-washy, right? It is from now you begin to do gradually. Most people also do it wishy-washy. Now, the other experimental study, right? You can see it below, but let me not go into there. I'll come to it when I want to do experimental study design. So now let us go back to where we were. Now, if you can see under descriptive studies, you look at what you find there: case reports, case series, cross-sectional, ecological, and more. So let's now go into descriptive studies. So we'll start with that aspect. So what I've just given you is an overview, types of studies. And all of this gives us the strength of evidence we need. Depends on these study designs. For instance, descriptive studies are the least, followed by analytical studies where we have the case control, the cohort, and the historical cohort or retrospective cohort. That's moderate evidence. Then high-level evidence is given by the experimental studies. So when you go this for descriptive studies is low evidence, or in fact, well, weak evidence. Let me say low, weak evidence. Moderate evidence, analytical studies. High evidence, randomized control and non-randomized control trials. They have high evidence. Among these, highest is randomized control trial. So if you follow in terms of hierarchy, randomized control trial is higher than non-randomized, which we also call quasi-experimental studies, right? So when you're looking at hierarchy of research evidence, original research, there is something called original research and review research. When it comes to original research, the highest is randomized control trial, followed by non-randomized control trial, followed by analytical studies. And among the analytical studies, the first highest in ranking is cohort studies, then followed by historical cohort, then followed by case control, then followed by descriptive studies, right? So that is how, the cross-sectional studies. Now, let's look at the descriptive studies. This type of study is the first step. You see why it's weak in evidence? Is the first step in understanding the health and disease problems in a given population or in a given area. Is the first step. That is why it's weak. What does it do? It describes the magnitude, frequency, and perhaps distribution of disease in terms of persons affected, places affected, and time within a population. Okay? All it does is description, and that is why they are called descriptive studies. They describe the people who are affected by them. Is it students that are affected? Is it healthcare workers? Is it general population? Is it welders? Is it any other occupational group? So it describes in terms of persons. It describes disease in terms of places the disease occur. Also describe the disease in terms of time, okay, within a population. Maybe the disease occurs in rainy season, or maybe dry season or harmattan. Time variable, time, or disease occur any particular time, or the disease that occurred last week or 2 years ago, outbreak that occurred at so time. So that is time element of it. So that is why descriptive studies respond or answers to the question who, where, and when. Who is affected, where is affected, and when is affected. Okay? Now, this who, where, and when, most times they are social demographic characteristics. And those social demographic characteristics, most times we'll call them universal variables, right? So the objective of doing a descriptive study is to provide data regarding the magnitude of a disease, or to provide some clues about disease etiology, which is causation, what led to the disease, some clues, though that cannot be easy, okay, to in terms of, well, there are other reasons. Okay, now we also do this to provide information on any group of persons, okay, or evaluate trends of disease. For instance, we want to see if TB is been increasing in our population, into society or not. That's when we are looking at trend. Whenever we use the word trend, it means a long-term occurrence, something that has been occurring over a long time. 8, 10 years and above, we look at trend. Just liken it to weather and climate. You know, weather can change in hours. From now, it has changed. It was raining, and the next 30 minutes, 1 hour, you see sunshine. You give it another 2, 3 hours, another heavy rainfall. You know, that's why at times people say weather is not predictable, because it changes very frequently. But climate does not. You have rainy season, you have the wet season, you have dry season. In temperate regions, you have the winter, you have the summer, you have the autumn, you have the spring, you know, so different, or some call autumn, fall, the fall season. So that's why weather changes rapidly. So whenever you are looking at trend, you want to see if TB, for instance, has been increasing in our society, or it's been declining, or it's been stable. So these are research studies that can be done for purposes of carrying out intervention, or looking at evaluating or assessing intervention program. For instance, we are conducting TB elimination program. Then we begin to track the incidence of TB over time to see whether our control program is working. If the incidence, new cases of the disease are declining, then we know it's working. If it is rising, then we know, oh, our program is not working. Maybe we need to tweak the program. We need to make an adjustment. We need to find out why it's not working. Or if the incidence has remained, the incidence rate has remained the way it used to be over the past 1, 2 years while we are carrying out, then we know that our intervention is not working. So we can use to look at health trends, okay? Then make comparison, of course. To know that it is not working is when you see it's not changing. And for you to say that, you must compare to know whether it's changing or not. Or to provide information for planning or for evaluation. Information for planning, for instance, if we need to deploy more resources, if it's increasing in terms of medication, healthcare manpower, equipment, more facilities, and the rest of them. That is where planning comes in. Then, of course, the most important thing here is for these descriptive studies is used to generate hypotheses. And this hypothesis can now be subsequently tested to see if they have relevance or not. Generating hypotheses, for instance, hypotheses are presumptions. You say, for instance, TB cases has not been declining in Rivers State in the past 5 years. And hypothesis usually, the null hypothesis is what we call the default. Okay? There is no statistical significant difference between this and this. So that is null. Then alternative. Okay. So we use it to generate hypotheses. And hypotheses, they are not conclusions, they are assumptions. So when we have used it to generate hypotheses, then we can now test those hypotheses using analytical methods, either case control, cohort, or historical cohort, or experimental studies. So the advantage descriptive studies have is that we can generate information very quickly with them. They are usually not very expensive. And of course, we can repeat this to use to generate hypotheses. The disadvantage is that it has weak strength of evidence. Weak strength of evidence. So most of the studies you are going to be carrying out belong to this group, right? Belong to this group. All right? Then examples of descriptive studies are case reports. Case reports are a description or a description of a single individual case or some group of cases, right? At the same time, which presents in an unusual manner. You and I know, in fact, your friends know, when you tell your friend, I've been having a headache, I've been having some slight fever and slight cough and all that, weakness, body pain. The first thing they will do for is, they will ask you, have you taken anti-malaria? Because the person knows how malaria presents and the things you have complained about strikes like malaria. So he's quick to make a diagnosis and of course recommend that you should go and take anti-malaria because the complaints you have made presents like malaria. However, some diseases might present in an unusual manner, which we call atypical presentation, presentations that are not typical of that disease. For instance, okay, the person, you made these complaints and he say, go and take malaria. And it turns out not to be malaria. And indeed, it turns out to be Lassa fever. Okay, so what does case report now say? Is that you have found an unusual presentation of malaria or Lassa fever mimicking malaria. And the import of case report is that it goes to inform other practitioners, physicians, that see, whenever you have this type of presentation, please do not always think about malaria only, because this form of, it could also present this other way. That is just the importance of this type of research. When there is a disease presents in an unusual manner, okay, an unusual manner. So You can write a case report from your practice if you make such observation. Examples are provided here. For instance, an experience of acute encephalopathy that is associated with metronidazole therapy. I will explain what I mean here. Take, for instance, encephalopathy. Let me put it in a simpler way. Somebody goes into confusion, loss of consciousness, simply because he took this drug called metronidazole, which we commonly, popular name of metronidazole is Flagyl. Some of you I call Flagyl. Quite a number of you will know it, but the actual chemical name, Flagyl, is just a brand name. Many countries and many companies call it the various name, Metrogyl, that is and that of that. But the actual name is metronidazole. That's the generic name. And in medicine, actually, we advise to use generic name because you can't be promoting one product over another. So we know that in every way of, scientifically known that drug does not cause that type of side effect at all. And you'll find that unusual presentation. You can write a case report, publish that in your practice you observe this, so that people should be careful with the use of metronidazole. Or if you have a treating patient with metronidazole and you begin to find signs of encephalopathy, you probably need to discontinue metronidazole. So that is the import of this as a case report. Or you see gastric TB of the stomach, right, coexisting with chronic peptic ulcer in an elderly. You probably will be treating for peptic ulcer, not knowing that this person has a coexisting disease like TB alongside. And now it becomes intractable, not responding to medication. Okay, unfortunately, the person dies. And you are concerned and worried. Why? We gave everything for ulcer. What would have been? Let's go to autopsy. Let us see. And it's opened up only for you to find out it was TB. So the presentation mimicked chronic ulcer, maybe because of the coexistence. So you are writing a case report to broaden investigation among physicians. That these are possible. Or the other one, fetal alcohol syndrome in a baby born to a 15-year-old. A baby born to a 15-year-old rarely should suffer from fetal alcohol syndrome. Fetal alcohol syndrome is suffered by babies born to alcoholics, right? And if we observe the signs and symptoms of fetal alcohol syndrome in a 15-year-old, it tells a lot about that 15-year-old, right? So we might do further investigation and all that because it's a lot of information. It shows us about lifestyle and all that. So these are just the import of this thing. Or let me go up quick. Then the other one is case series reports. Case series reports are when cases are coming in series. Imagine you are overseeing a secondary school, boarding house. The children took breakfast. They went to school. By noon, 1 or 2 children have started stooling and vomiting. By 2 p.m. to 3 p.m., another 2 they were taken to the sick bay. Another 2, another 3 has joined. By 6 p.m., another 4. In the entire day, more than 8 already. By the next day, another 5. So these are cases that is reported in series, one after the other, one after the other. Here, whenever we see case series, the first thing that comes to our mind is an outbreak. Maybe in this case, maybe food poisoning right? An outbreak, food poisoning, or whatever. Another good example for case series report is when a very observant physician in San Francisco in 1981 observed pneumocystic carinii pneumonia among homosexual male men in San Francisco. So usually pneumocystic carinii occurs when people's immune system are severely depressed in very elderly people, right? People suffering from several chronic diseases. Maybe they are suffering from cancer. Maybe they are suffering from CKD, that's chronic kidney disease, or maybe liver cirrhosis or whatever. So these chronic conditions on their own can lead to immune depression. So when we find that in those category of persons, it is nothing new or surprising. Okay? But when you find it in a young adult, in this case, they happen to be homosexuals. So the physician got worried that something untoward is in the offing. Something is happening that is not usual, because this type of disease is not prevalent in this group of population. Okay, that concern. So another thing he now found that they were homosexuals and living in a particular area, maybe one joint area in, some of these diseases, they cluster. We call it clustering. Okay. It is there from that example when further investigation, then when he investigated, examined them further, he observed that they had lymph nodes everywhere. Lymph nodes in human body, when you begin to palpate, feel the lymph node, then it's enlarged. Lymph nodes are usually not palpable. They are there everywhere. They can only be palpable if they're inflamed. So he saw generalized, lymph node. He called the palpate lymph node everywhere. So he made a proposition, or a hypothesis, that this disease, that this homosexual are suffering from a peculiar disease that has a predilection for the lymphatic system, the lymph vessels and the lymph nodes. That's why the lymph nodes are enlarged. All right. So he thought it was a viral disease, but of course, he does not know. So the first name the disease given to the disease was lymphotropic virus. Lymphotropic virus. Lymphotropic virus is simply a virus that has, effect on attacking the lymph nodes. It was now found that it was a virus that destroyed the immune system, and a conference in Paris now named it immunodeficiency virus, human immunodeficiency virus. That was how HIV was found, came up. All right. So we praise the physician for being observant. And that is why when somebody goes to the clinic, you can make all the diagnoses simply by observing and questioning, taking a proper history. You 80-90% you have clue. It is not true, absolutely nonsense, that until you go to the lab, that is just very myopic view. No, that's just, maybe if you are in doubt, maybe let's exclude this perhaps. It's not mandatory. This thing was from a case series report from toxic shock syndrome. There's a diagnosis called toxic shock syndrome. If there are physicians among you, you know what I'm talking about. Toxic shock syndrome. This disease affects women during the menstrual period. It was only found out that it came as a result of Staphylococcus aureus, right? Because Staphylococcus thrive very well with blood. And it was as a result of a particular type of sanitary pad made those days by a company called Procter & Gamble. Procter & Gamble made those pads, right? And women who were using it developed toxic shock syndrome. And when these things were found, it now discovered that the production, there is asepsis, or how will I put it for you? That the process of making it sterile was broken and there was contamination during production. So that contamination during production led to toxic shock syndrome in some people. It was discovered epidemiologically. Then all those group and batches were removed from circulation and destroyed. Now, another one, a drug called thalidomide. Thalidomide was previously used in pregnancy among pregnant women. For instance, when women are pregnant, some do have what we call, early morning sickness. Medically, we call it hyperemesis gravidarum. Hyperemesis gravidarum. Now, that is vomiting, feeling unwell and vomiting and all that. It's simply early morning sickness. As the pregnancy grows, it's overcome. But for some people, people tolerate it differently. Okay? Tolerate it differently. So this, one of the ways that is handled in the clinical setting is to give some mild sedative, like diazepam and, Phenergan, some of these mild sedatives to prevent vomiting, and she will be all right in a few weeks or few days, in a few weeks. It was now discovered that women who were prescribed this sedative, thalidomide, when they gave birth, there were numerous birth defects, defected limb, eye, head, different, So that drug was, of course, discontinued. It was investigated and found that the drug was responsible. So it was discontinued. And when it was discontinued now, discontinued the use in pregnancy, but it's not completely discontinued. It is still used for other purposes in cancers, right? In some cancers, management of some cancers. Now, in spite of these limitations, you see, these studies are limited. They are limited in the sense that they are not usually generalizable, because it occurs among a small population, and it becomes difficult. If it is case report, one single case series, a few cases. So it's not generalizable for the entire population. We'll say in epidemiology that it lacks, or in research, we say it lacks generalizability, or it lacks external validity. You cannot generalize it everywhere because it's conducted among a limited population. However, in spite of those limitations, there are still some relevance in some of these studies. For instance, now look at the whole problem of HIV was just from that study. Other so they are not utterly useless, right? But further research about them needs to be done before conclusions are made. All right. Now, here I say many known human environmental toxicants like methyl mercury, asbestos, tobacco smoke, radon first came to attention in case reports and case series reports developed by astute clinicians, pathologists, and healthcare workers, right? So that is one. Then surveillance reports. Well, surveillance reports are also descriptive studies. For those of you who are healthcare workers, you know what the surveillance system is. These are diseases we track in our healthcare system. We don't track every disease, but we track some because of their importance in our society. We track them, right? We track those diseases. If we analyze them, we can obtain surveillance reports. When we analyze them, we obtain surveillance reports. Because of we track them in order to know whether they are rising, whether they are falling and things like that. But our interest is mainly whether they are rising. Because when they are rising, if the rise is dramatic, more than 2 times the usual or regular occurrence, if the rise is more than twice the usual or regular occurrence, then what do we say? We begin to infer that an outbreak has taken place. An outbreak would have occurred. We begin to investigate for a possible disease outbreak, right? We begin to, or an epidemic in worst case scenario, epidemic. So that is how it goes, right? So surveillance reports are also descriptive study reports. Let me just, then the other one, the big one among this group is called cross-sectional studies. Most of your work, 99.9% will belong to this group. Cross-sectional study, descriptive cross-sectional studies. Because there are descriptive other case reports and all that. All right, so cross-sectional studies is the one people usually call survey report or survey study, or surveys, where you develop questionnaires and ask people questions to collect data, analyze it, and produce the results. Okay, so the unique thing about this is that they are called snapshot studies. Snapshot in the sense that it describes what is available at that particular point in time. It has no clue or information for us what preceded that event or that day, or what is likely to happen in the next 1 day or 2. We don't have that information. So we say it lacks a cause-effect relationship or exposure-outcome relationship. Or if you want to use a good epidemiological term, we say it lacks temporal relationship or temporal sequence. A sequence, one after the other or one before the other, right? Somebody will be exposed to a disease or a disease hazard before he develops the disease. So in this type of study, you will not know, we don't have information what led to what. If we see we find out that we measure somebody's blood pressure and it's raised, that's all we can say about that person. We can only describe the person is a male, is of so age, of this ethnic group, of this socioeconomic status, his or her BMI is this, the height is this, and things like that. That's all we can say. What pertains to that person at that material time, that's why we call it a cross-section. You know, when you cut, remember your biology, you make a cross section of a stem. That picture or with snapshot, when you take a photograph, the photograph in actual fact tells you what you can see in that material time. It does not tell you what happened before or what is likely to happen in the future. But you can see everything that is occurring at that particular time. That is why, so it has that limitation. So because of that, you can also use it to generate hypotheses that can be now proven. That is with other methods, analytical methods. Okay, so that is typical examples of cross-sectional studies, the one we call CAP studies. Knowledge, attitude, and practice, prevalence of this and this, factors associated with this and that, and all that. Screening test. You go and do screening. Maybe you are looking for women who develop breast lumps. You do breast self-examination and things like do some form of screening, TB screening, HIV screening, and all those are cross-sectional studies. All right, so the benefits here is that one, they provide information about prevalence of disease at that material time. Whether it will reduce going forward, we don't know. What led to the disease, we don't know. Okay. They are usually inexpensive because it's just at one point in time is conducted. They provide information about associations and risk factors. Yes, when you do an analysis, when you do cross-tabulation, bivariate analysis, you want to see, maybe you find out you measure blood pressure of males, and you've seen maybe 250 males, you measure the blood pressure. Okay, having measured the blood pressure, you can categorize them by age. Maybe those 50 and above, you can have higher percentage of blood pressure compared to those who are, lower in age. Okay, now you can cross-tabulate this blood pressure with socioeconomic status. You can cross-tabulate it with educational status. When you cross-tabulate, you might find out that those who have higher education have lower blood pressure. It is possible because they are taking drugs at that time you measured. It is also possible that they are observing certain lifestyle that make them not prone to having high blood pressure. So those are the things. So when you cross-tabulate, you can use it to see associations and risk factors. So they are useful for planning, for resource allocation, for evaluation. If you find out high blood pressure is prevalent, you begin to plan on what to do. You begin to allocate resources, equipment, manpower, facilities, and the rest of them. If maybe you are carrying out intervention programs, you begin to evaluate outcomes. If these intervention programs are really yielding effect or not. So another advantage is that they usually have few ethical issues. Few. Mere informed consent is sufficient because there is no experiment. We are not carrying out any form of experiment. There is no human experiment, nothing. So that is why there is like that. Okay, it has few ethical issues. Now, the disadvantage is that it does not have a temporal relationship or cause-effect relationship. We don't know much after the fact that we saw a raised blood pressure. We can't say further. What caused it, we don't know. And we would have loved to know in order to prevent it. So it has that weakness. Or the dangers is likely to bring about going forward, we also do not know. Would have loved to know. So that is some reason. Then we have ecological or correlational studies. These studies are what they call statistical connection between disease and exposures in the population group. They are mainly based on data, statistics collected for other purposes. For instance, you will all know who the National Bureau of Statistics in Nigeria is. National Bureau of Statistics is one agency of government that collects data across board, from amount of tomato price to meat to anything you like, just, all variables as much as possible for national development. So, and you being perhaps a physician or somebody who has knowledge in research and in healthcare, you look at the data of National Bureau for Statistics and you see that, take for instance, meat consumption is high. Meat consumption, or not, the amount of money the Nigerian government is spending on importing meat and locals runs into a lot. Good. And on the other hand, let me not use meat consumption. It's not a very good example. Let's use the example I use here. Take, for instance, we spend a lot of money importing tobacco and tobacco products. If you check our GPA, a lot of money is spent on that. And we know from science that tobacco smoking is adverse to healthcare, or tobacco smoking causes lung cancers. That we know, right, from our health science. Now, we begin to create some theories in our head that, for the fact we see some correlation there between high amount of money spent on tobacco import into the country, because that's how we consume it. And we see also a rise in lung cancer. Now, the next thing that enters our mind, we see a correlation, and a positive correlation. Correlation is two ways, positive or negative. An increase in national spending on tobacco correlates positively with increase in national prevalence of lung cancer. The next thing that agitates your mind, you are trying to make a connection between the two. No wonder cancer is on the rise, because we are consuming a lot of tobacco. So you can generate a hypothesis that high consumption of tobacco leads to high incidence of cancer. That is your hypothesis. Now, what did you succeed in doing? You only succeeded in generating hypothesis simply based on data collected by National Bureau for Statistics for whatever purposes, not anything not related with healthcare. But in your nosy nature, you have observed this correlation, right? And you now want to look at, whether truly a correlation exists, right? So you carry out a study like that. They are called correlational studies. You use certain test statistic to determine the correlation. Things like Spearman R or Pearson R and Spearman Rho. Pearson R and Spearman Rho. These are test statistics for correlation. So here I give you an example. Example is the observation that death rate from coronary heart disease. Coronary heart disease is disease of the blood vessels, correlates with per capita sales of cigarettes. High consumption of meat correlates with increase in the occurrence of colon cancer. From the same data, you've seen high consumption of meat on one side, you saw increase in, and you begin to, because of your health knowledge, okay, or high consumption of salt rises, increases the occurrence of, relates with esophageal cancer. Okay, and you can see some correlation like infant mortality rate will be associated with low immunization and low breastfeeding. So that when you see infant mortality rate is high on one side, and when you go to immunization rate, you see that the immunization rate is low, and you begin to explore that relationship. Such studies are correlational studies. We use them to generate hypotheses. That is their import only, and it ends there. However, ecological studies can provide important clues or causal relationships. Yes, they have done so in the past. Take, for instance, today, all of us, all the toothpaste we use have fluoride in them. It was found to prevent dental caries, tooth decay, right? And this was just on the basis of observation. It was observed that where fluoride or, was found in the soil, some areas where fluoride was found in their soil, people from that area never ever developed tooth decay. So investigation went on, because water and soil, all the water we take, they flow through soil, only to find out that the water they drink was already containing a lot of fluoride. And investigation now continued to now find out that fluoride prevents tooth decay. So now it is generally applied everywhere, to the extent that it's applied in all the toothpaste we use, so that people will get some fluoride in their medicine to prevent tooth decay. The same thing with iodine. The consumption of iodine prevents the development of a thyroid disease, right? Enlargement of the thyroid gland. Okay. Now, what do we have? By policy, you cannot even import salt that does not contain iodine in Nigeria. It's prohibited by law. For public health safety, every salt must contain iodine, because iodine prevents the development of thyroid disease, thyrotoxicosis, and the rest of them. So ecological studies also suffer from serious weakness. All these studies I've been mentioning, they are weak studies for now. They assign group exposure levels to only members of a group. Okay, only one group. The other we don't know. They fail to control for individual confounding factors, because those studies are for other purposes. They are not tailored for your medical research. It is you that carried yourself into that place to make those observations and now want to test those hypotheses that maybe lack of iodine in their salt or in their soil will lead to thyroid disease. So one important thing I must say about ecological factor studies is what is called ecological fallacy. So it is a major drawback for ecological studies. And the fallacy means drawing inferences or an inference incorrectly, of course, from data on a group or data from a group on an individual. Let me explain. If maybe we found that per capita consumption of cigarette high, lung cancer is high, we see that ecological relationship correlation, and you have a friend who is a smoker, and you are warning him that if he doesn't stop smoking, he's likely to have lung and die from lung cancer. If you do that, you have committed ecological fallacy. Why is it fallacious? Why is it a fallacy? It is a fallacy because that data you are seeing from National Bureau of Statistics is population-based data, the entire population. You cannot use observation from that population-based data on an individual. If you try to do that, you have committed ecological fallacy. Where you say high consumption of meat can lead to esophageal cancer, then you have your girlfriend eats meat a lot, every time be eating meat, and you say, I've been warning that girl, she will get esophageal cancer, this thing, colon cancer. That's ecological fallacy, of course. Why? The same reason. You cannot use group this thing and transpose to at individual level. It's not explainable at an individual level. So that is that. Then cluster studies are descriptive studies too that takes place in clusters. Clustering, clumping together. Look at grapefruit, the cluster. So it's a descriptive study in a particular geographical area. It can be among occupational groups. A university can form a cluster among students. And a correctional center can be a cluster. It can be among a small group, like that. So when you go to carry out studies in a cluster, the important thing we take note of is that most clusters are identical. Most communities are clusters. If you check, most communities are as a result of either some form of kindred or anything. If you try in Port Harcourt here, you see Rumu this, Rumu Kalakbo, Rumu this, or in other places also. There are usually a long-term genetic relationship, right? Even though you can see intermarriage, after third, fourth cousins, people can marry. That doesn't mean that they are two genetically distant apart. So most times, when we are conducting studies in clusters, we do what we call consecutive recruitment. 1, 2, 3. Why? Because they all have identical characteristics. Most clusters have identical characteristics. You can have a cluster of sex workers, the area, the red light zone, okay? And you can trace, when we are tracing sexually transmitted infections, we look at those areas because they have customers, those patronize their services. Some diseases exist in clusters, right? So maybe these are some of the, okay, let me go on. Okay, that is this for this first one. Well, maybe it's either I confuse you or you learn one or two things. So now let me quickly go to, please, I don't like if you are using, I've encouraged you, I've advised you to put your proper name. I want to make sure that it's my students that are here. Those of you are putting HP, this I will remove you and I'll block you from entering this place. Please, please, I'm begging you now. Put your proper name. This is a class. Even though we are not seeing you face to face, it's a class. I am live here. It's a class. It's not a recorded message. So please, I've said this severally. I don't like a situation people come in. You make me feel, why are you hiding your identity? Why? Why will you even ever do that? Infinix Hot 50 or what, Hot 3000, I don't care to know. If you don't remove it, I'll just delete you completely. Why is it that we can't obey simple instructions? Or if you don't want the lecture, you don't want the lecture, I will walk out. I am even too tired to give this lecture. I just got home 13 minutes past 5. I just dropped my things, removed my clothes, and entered here to give this lecture. So me, I'm already tired. I don't want extra stress. If you don't want to obey the instructions, well, we can't work together. I will walk away and go and take my well-deserved rest. I've told you, even if you are using iPhone or X phone, I don't want to know. Put your name. Put your name. Let's know you are a student here. This is the last time I will say it. Why can we be lawless? I've said it severally. It's not the right thing to do. We need to know who is here and who is not here. We snap this and take attendance. We know. We can't put a name to Infinix or iPhone or Techno or HP. No, that's not right. Put your name. You have a name. All right, so let me share my next slide. Let's see how far we can go. Okay, let's look at the one that this one appeared a bit quite easier. I'll look at another one, another example, maybe slightly more, but not much actually. Let's look at analytical studies. Let me see. All right, this one. Okay, this about analytical studies. I'll give you examples of analytical studies. So, analytical studies, in contrast to descriptive studies, analytical studies or analytic studies are based on more individually detailed data analysis. Okay, analysis of the risk factors. While descriptive studies is asking the question of who, where, and when, analytical studies, this thought. Okay. Yeah. Can you see my screen? Okay, you can put on the chat box. I forgot that I muted you. Put on the chat box if you can see. Just say yes. All right, great. Thank you. Okay, analytical studies, right? Analytical studies answers or responds to the question of why and how. While descriptive studies just merely describe what was seen at that point in time, analytical studies goes a little bit further. That's why they are more, they are higher in hierarchy. It wants to know why it happened and how it happened. It wants to know why and how. Okay. So analytical studies, they offer the opportunity to control for confounders. Confounders or confounding factors, right? These are factors that can taint the effect of an exposure or an outcome. Take, for instance, let me give you one interesting example. What I mean by confounding factors or confounders. We want to look at the effect of adynamia or sedentary lifestyle when somebody is not involved in any form of physical activity or the other. Right? We want to see how that affects cardiovascular diseases. We want to see the effect of adynamia or sedentary lifestyle on cardiovascular diseases, diseases of the heart. Then our study population, we went and chose elderly people. Now, there are certain things that play out here. Age will be a confounder or a confounding factor. Why? We know that first and foremost, when people get aged, they become less ambulatory. Their physical activity declines. That is one. Two, when people get aged, we know that cardiovascular diseases increases with age naturally. So if we want to see if sedentary lifestyle affects cardiovascular diseases, then we cannot use old people as study participants. Because if we use older people as study participants, any effect we find, we will not know whether that effect is a result of their age. We know whether it's a result of their age, because their age can make them inactive. Their age can also make them prone to cardiovascular diseases. So if you are doing a study now, you present to me a study and you found so, you are beating your chest, you have made some discovery that sedentary lifestyle leads to the development of cardiovascular diseases. Fine. And I look into it. I saw your study population. A lot of them are elderly. I won't bother to read it again. Because there's a confusion for me. Because I know that age itself can cause that. Right? So in that case, that study is not valid. That is what is called a confounding factor. You know? That is what is called a confounding factor, a confounder. in research. All right, so analytical studies are usually more costly and more labor intensive. They are more laborious. It's more technical a bit to conduct. Information from medical records, clinical or laboratory investigation, questionnaire results, or direct measures or estimates of exposure may allow analytical studies to test hypotheses about suspected causes of disease. So for analytical factors, studies, we can begin to infer causality if the outcome is very high. Maybe we do we see the relative risk or odds ratio is very high. We begin to suspect causality. Though that is not enough, we must follow what we call I think that will teach you later, the Braxton-Hill's, criteria for causality in epidemiology. All right. So analytical study answers the question of why and how a disease or risk factor of a disease occurs. So with analytical study, we can now begin to know why it occurs. So if you want to carry out a study to know why a disease occurs, how it occurs, then you know that you are going to do analytical study. It will help us to test hypotheses that has been generated through descriptive studies. Okay, it can help us to clarify determinants or risk factors in disease etiology. Then, if a relationship exists between the suspected factor and risk factor and a disease, it helps us to specify or authenticate if a relationship exists between a suspected risk factor and a disease. With analytical studies, we can do that. Now, give us classic design of analytical studies: case control studies, prospective cohort studies, that one I call cohort studies, retrospective cohort studies, the one I call, retrospective historical cohort, then nested case control or case cohort studies. These are additional, these ones are called hybrid designs. I'm not going to bother you with it. I won't bother you with it, but the slides are there. You can read them when I give you the slides, so that you understand what the hybrid, they are. They can all be identified. I don't want it to be too much. If for those of them if you are doing a higher level study, maybe you are doing a doctoral study and things like that, then we can begin to look at some of other details, right? But for this level, I don't want to discourage you before you run away, please. All right. So let's look at case control study, cross-sectional study. Remember, I told you that. Look at here, past, present, future. When you are doing a snapshot study, descriptive studies, cross-sectional study, what you are doing here is you are looking at whatever that is present now, the one that is present now, in the present. When you are doing prospective cohort, from the present, you are looking into the future. When you are looking at retrospective cohort, we use the same color so that you know it's the same type of study. You are looking from present here, but you're looking at the past. This one used to confuse a lot of students, but I will try and break it down, because at master's degree level, you should understand this, so that when they say you have master's degree from the University of Port Harcourt, of course, then you know who taught you and how you. Well, not many people understand it from elsewhere. I've interacted with them. Then case control study, also looking at in the past, like, but there's a difference. Just as the colors are different, they are different. Then randomized control trial, also different. Even though it's looking forward, it's also different. Then, of course, the time. Okay, let us look at it one after the other. Case control studies. As the name suggests, just listen to me. As the name suggests, Okay, as the name suggests, this study is about cases and controls. It's about cases and controls. That's why it's called case control. Cases and control. Please, cases and controls, as the name suggests. Let me give you a typical example. Now, take for instance, we want to establish the fact that smoking leads to lung diseases like chronic obstructive pulmonary disease. Okay, let me not go. I realize that all of us are not doctors. Let's say smoking leads to lung disease. Let's just put it that way. Lung disease. We want to establish that fact by experiment. Okay? By a case control study, not experiment, sorry. So we look at people who have developed the lung disease. Let's assume that lung disease, okay, lung cancer. Good, lung cancer. Not just lung disease, lung cancer. Lung cancer. So we identify the people, the few persons who have developed lung cancer. We now identify a similar group of individuals comparable to these ones, similar, comparable, similar in terms of demographic attributes, age, sex, in terms of socioeconomic attributes, right? Income, standard of living and all that. In terms of education, similar. So we have two groups of persons that are similar in every other aspect, except that one group has lung cancer, but the other group does not have lung cancer. But they are similar. You know, we say when you are comparing, you can't compare apples and oranges. Whenever you are comparing and the groups are dissimilar, it's not a fair comparison. We can't have one comparison group, adults, and the other one, children. There are characteristics difference in both population. We can't have one males, the other one females. No. We can't have one group, so poor people with lower and the other group very rich people. Their lifestyles are different. Okay, so here we have two groups. The case group who have the lung cancer and the control group who does not have the lung cancer. Now we look into them, maybe their occupational history or their lifestyle in the past. Maybe in the past several years, in the past 30 years, we look at the group that has lung cancer and we develop our question and get inquiry from them about their smoking habit in the past 30 years. How they smoke, for how long they smoke, and things like that. How much quantity they consume when they were smoking and all that. So we looked at them. We documented them. We look at the other group that did not smoke and ask them detailed question about their contact with smoking or among friends who smoked and the rest of them. That group. And maybe we find minimal history of, the smoking. Then when we look at those groups, we see of course, we have seen a few cases. Then we look at the groups that smoked throughout. We could find more cases among the group that smoked. And we look at the group that didn't smoke. We could find a few, one or two cases among them who have lung cancer. Okay, then we go further to try and analyze our result, having collected our data. But look at this scheme. Look at direction of inquiry behind. So we have two cases and control. Please, this is a mistake. Here, if you look at it, they are similar. Cases, those without disease. No, cases are those with the disease. You see, so anybody can make error. I got this from the textbook, but I don't know how to do this. I'll try and edit it, and if it is possible, but I'm using it because I like the diagram. You explain it, so that you can catch it. Because cases cannot be people without disease, and controls people without disease. No, controls are people without disease. Cases are people with the disease. Those are disease cases. So we found a few cases. Then we found similar controls. So we go back among these cases in history over time, ask them about their exposure and non-exposure to tobacco. The same thing we do about a similar comparison group. We ask them about their exposure to cigarettes or not exposure. So we look at these two groups, those who are exposed to cigarettes in the past and those who are not exposed to cigarette. We look at this group cases, those who are exposed to cigarette and those who are not exposed to cigarette. Now, when we do that, we go further to do the analysis. Okay, let me explain a few things for you in terms of the selection of cases. Now, look, let's see. To test the hypothesis that cigarette smoking is an important factor in the causation of coronary heart disease, or say, in my case, maybe lung cancer, right? We get two similar groups that are matched in all characteristics, except that one group has and the other group does not have. So controls do not have the disease, right? While the cases have. So we compare their past history regarding smoking, maybe over the past 25 years. That is why we are comparing their exposure, their past history. So we observe any significant difference in maybe lung disease, cancer, among those who are cases who are smoking and among those who are not smoker. Then we test the odds ratio or the probability of occurrence of that disease, in this case, lung cancer. And how do we do that? How do we do that? We construct a 2x2 table. I'll go back to explain the other aspect for you. Since I'm talking about this, let me exhaust it. We go back to do a 2x2 table. This table you see here is called a 2x2. Now we see these are cases, right? Now this column will have cases, this no cases or control. These here exposed, those who are not smoking, unexposed, those who are not smoking. So what do we have? A is those disease with the disease and they have a positive history of exposure, smoking. Among those we examined, we found some that have the disease and at the same time, they have a positive history of smoking. Then C, below, those also with the disease but have a negative history of smoking. Why? Because smoking might not be the only cause of lung cancer. So they have the disease, but they are not smoking. Their lung cancer could have come from some other sources, right? Okay. Now, B, those without the disease, the controls are healthy people. They are without the disease, but they have positive history of smoking, which tells us that it's not everybody who smokes will develop lung cancer or cardiac disease. It's not everybody. Now, the fourth one is those without the disease, and at the same time, they also have a negative history of disease. They do not have the disease and they have never smoked. So if we follow that diagram, this is the 4 scenarios that will evolve, right? So for this case control study, what we do, we calculate the odds ratio, which is also named estimated relative risk, right? We calculate the estimated relative risk because why? We cannot be able to determine when the disease occurred, disease incidence. We do not know when they develop lung cancer. We only examine them to see that they have lung cancer. So disease incidence is about new cases of diseases. Those you saw develop, that's incident cases. Prevalent cases are those who are there, mixed, old and new, because some old was just yesterday, some was last year, right? So because we cannot say when the disease developed, what we can calculate is the probability of the occurrence. And that is why it's an estimated relative risk. And it's called odds ratio. So let's take a scenario. Let's replace A, B, C, D with numbers. Among those who have lung cancer, and who were smokers are 7. Among those who were smokers but did not have lung cancer are 93. Among those who are smokers, non-smokers but had lung cancer 2. Even though they are non-smokers, they still had lung cancer, because it's not only smoking that causes lung cancer. Then also, they are not smokers, and they also do not have lung cancer. That's why I say lung cancer free. They are 98. We do calculate the odds ratio. Another name for that calculation is cross-product ratio. Cross-product ratio. You see, this is what they call cross-product ratio. If you cross it like this, you have the same as this. So we look at the ratio of the odds. The odds is the probability. Remember, if you did, well, I'm sure everybody here did mathematics now, or further maths, whichever. You did probability, yeah, basic mathematics. The odds of exposure in lung cancer among those who are smoking versus those who are not smoking. So the probability of lung cancer among smokers over the probability of lung cancer among non-smokers. When you calculate it, right, what do you have? 3.7. Okay. Or a shortcut method is to do cross-product ratio. So when you follow A, B, C, D, you see what I mean. You just substitute with this value. A over B means 7 over 9, 93. C over D means 2 over 98. Whatever I give you, all will give you 98. So when you do it, you have the same, right? Okay, or if you substitute the figures, this is what you have. Now, you make an inference. What is the inference or the conclusion you draw from this study? Now, the general way we make inference is that if the odds ratio or estimated relative risk is 1, then we say that the exposure in this our example, cigarette smoking, has nothing to do with the occurrence of the disease, which in this case is lung cancer. Why? It means that the number of lung cancer cases is the same among those who are smoking and among those who are not smoking. So if among those who are smoking, 7 cases have lung cancer, and among those who are not smoking, 7 cases have cancer, then we can tell you, my dear, it is not smoking that caused the lung cancer. Because 7/7 is 1. Whenever the estimated risk or odds ratio is 1, then that factor of exposure has no relationship with that disease. For that factor of exposure to have a relationship with that disease outcome, the estimated relative risk or odds ratio must be more than 1. In our own example, we saw that it was 3.7. How do we interpret it? We interpret it that people who are smokers are 3 to 4 times or 3.7 times more likely to develop, watch my words, more likely to develop lung cancer compared to those who are non-smokers. I did not say that people who are smokers develop lung cancer. I said because it's a probability that people who are 3 times and people who are smokers are 3.7 times, or maybe abbreviation, are about 4 times more likely. The probability of developing lung cancer among the smokers is almost 4 times compared to the non-smokers. That is what that result has said from the research. That's how you interpret it. Then, if on the other hand, we calculated the odds ratio is less than 1, it means that that exposure factor is a beneficial factor, it's a protective factor. It's a protective factor. Example, before now, we used to say moderate alcohol, like red wine, has beneficial effect on coronary heart disease. But latest studies from WHO is showing that any form of alcohol is harmful. So I will remove that from my note because it's WHO that said so. I will update my note. Right? Or take, for instance, immunization. If the study, that exposure we are talking about is immunization, instead of smoking, a group exposed to immunization, another group not exposed to immunization, we will find out that the odds ratio will be less than 1. Right? One group took immunization. We will see that those who took immunization developed less of the disease, and those who did not take immunization developed more of the disease. When we calculate, we see that it's less than 1. So that is why we say if the odds ratio or estimated relative risk is less than 1, then that factor of exposure is a beneficial one, right? So that is how it is, you were not listening. Somebody is correcting me that both are saying the same thing. I corrected it. I saw it in it, but I don't know how to remove it. That is, or rewrite it. That's why I just explained it. If you are listening, you would have known that I have corrected it. All right. The advantage of case control study is that, 1, it takes a very short period to conduct. Why? You are simply looking at data. In most cases, it's cheap. Why are you looking at data? You are not seeing those individuals. So you are looking at a cohort, people are with similar age, everything, characteristics. the only difference among them, and you analyze the data, right? You are not likely to look at the individual, but in some cases, if you can find the individual, if they have not died because it's 35 years ago, it requires a small number of persons to conduct, small number of subjects. It's useful for the study of rare conditions. Why is this useful to conduct rare conditions? If you are going to use cohort studies to follow up to see when a rare disease will develop, you might follow forever. It will not develop. So what do? The ones we have found that developed, we now try to see what exposure factor led to their development. Here, ethical issues, ethical problems are minimal because no one is deliberately exposed. Most of these have occurred in the past. Exposure took place in the past. And you can identify more than one risk factor. Maybe when we are looking for lung cancer, we could find out that we can examine and find out that heart enlargement is also there. But we could find out another disease. Apart from our primary disease of interest, we could find out others also. So the disadvantage is the issue of recall bias. Recall bias occurs because some of these things took place in the past, many years ago. So if you are using live patients, right, to conduct it, recall bias will be there. People would have forgotten what happened in the past. So they might not be very accurate with the history they are giving to you. But recall bias or deficiency in recall occurs more among those who don't have the exposure. Those who were exposed will recall everything, are more likely to remember everything because of the factor of regret. They remember how they smoked, how their life was in the past, how it was reckless. They can remember everything. And now look at what it has led me to. They are more likely to remember than the one who appear very naive. He didn't smoke, he can't even remember, those ones. So again, if maybe where you are using data from past records, missing information can be a problem from folders. Information supplied by an informant may be incorrect because they might have forgotten. Okay, that's where recall bias can occur. Selection bias might occur in the control because it could be sometimes difficult to find perfect matches. Yes, the other side I omitted is about the controlled matching, types of matching. I will go back there. I told you get control. You get this case group first before you have controls for them. Right? Yeah. So that can be difficult at times to match people and get the correct match. Here, it is difficult to identify the relative risk or disease incidence because it's something that happened in the past, so we do estimation. All right, the next one is prospective studies. Well, time is gone. Well, let me see. Let me see. Sorry, let me just stop this 1 minute and look at my schedule and see let me see how I can manage this thing for tomorrow. Okay. Today is Monday. Okay, Tuesday. Yeah. Sorry. Wednesday. Okay. All right. So, okay, let's go on. It's very tight for me. It's very tight because when I see what I'm supposed to do, bias and confounding, sample size, man, these things are so loaded. Maybe I will need an extra day. I will create an extra day, which is a Thursday, so that I'll be able to finish them because I'm slow so that you understand it. If I'm very fast, you will ask question tire. So I will create an extra day, but let me finish what I'm doing now. Then I will do some tomorrow. Then I'll create an extra day by Thursday to do the rest so that you can follow. All right. Yeah. All right. So that's about the case control studies, right? That's the case control studies. Yeah. So let's just finish this, then I will leave you for today. All right. Okay. Let me end it here. Let me end it here. I will take it gradually because a lot of you find this difficult. Let me end it here. I will send you the slides. So tomorrow we'll continue. So I want you to, sorry, I want you to, let me share that screen again. I want you to now ask your questions on whatever aspect you want to now ask questions. Okay? I ended with case control. So ask questions. Okay, let me unmute everyone. Let me unmute all. So now you can unmute yourself and ask questions. Okay? You can unmute yourself and ask questions. Okay. Eugenia. Okay, I thought you asked a question. All right. It's a thumbs up. Yeah, it's thumbs up. I took my time to explain. Okay. All right. Claire and Anigba.
Okay, good evening, sir. Thank you, sir, for your lectures. I really, really enjoyed it. So my question is on case reports. So you said case reports, they are unusual, they are reports of unusual diseases, and you gave an example of acute encephalopathy associated with metronidazole therapy. So my question now is on this case report. Can it be associated with idiosyncrasies? For example, anaphylaxis reaction from penicillin hypersensitivity.
Okay, anaphylaxis, hypersensitivity might not be very
Yes, sir.
suitable for case report because it does occur. We see it all the time. This case report is better for rare conditions.
Okay. Okay.
Yes,
Okay.
yes, for very rare conditions. Anaphylaxis does occur from time to time. All right, Ada
Okay.
Maneri, yes. Or you do
Thank you
have
very
another
much.
question?
Yes,
Okay, Ada, go on.
yes, sir. Thank you very much, Prof, for this very interesting lecture. My question has to do with cross-sectional studies.
Yeah.
Earlier, they said something about them being analytical, meaning now they now fell into analytical studies. You know, we have the descriptive cross-sectional and analytical cross-sectional studies. I mean, or
Yes.
comparative. So those comparative, I was a bit confused because you generalize them under descriptive. But
Yes.
I'm feeling that some can actually be analytical. So I needed a bit of clarification on that, sir.
Okay.
Thank you.
Okay. I agree with you that you are a bit confused. Huh? A lot of people confuse it, even in some textbooks. Well, you know, in higher learning, we have what they call schools of thoughts. So people have their reasons why they want to do things the way they do. right? Yeah. Okay, now. Now, some classify cross-sectional studies as descriptive, people like me. Others say because there is a comparison, it's now analytic. And I told you earlier on that the basis for classifying these studies, either analytic or descriptive, is based on the study design. A cross-sectional study is a snapshot study, which means there is no temporal relationship, no cause-effect relationship. What it is, you can only say what you are seeing at that point in time. What led to it, you do not know, or what it could probably lead to, you do not know. You are only making your assessment, observation based on whatever is present at that time. Every typical analytical study has a temporal sequence or a temporal relationship. Exposure outcome. All of them. Exposure outcome. Cross-sectional study does not have that. Now, for the mere fact that you are now trying to compare, maybe you do one cross-sectional in a rural community, another cross-sectional in a city, urban community, and you compare the two, how does that make it analytical? It is cross-sectional in the rural community, assuming you measure the blood pressure, you want to see whether blood pressure among people dwelling in rural areas compare with those dwelling in urban areas, whether they are similar or dissimilar, whether people's stress of life in urban or poverty in rural you are compared. You do a cross-sectional in urban, you do a cross-sectional in rural, and you compare the two. How has that now become analytical? So that comparison makes it analytical. My own sense of reasoning say no. Because, yes, go ahead. What do you want to say?
Okay, let me give an example, a clear example.
Yes.
For example, you're
Yes.
trying to check, let's say, there's a study I did once, the relationship between maternal hypertension and early neonatal blood pressure.
Good.
So what we did was that we checked the blood pressures of all of babies born to mothers who had hypertension and compared them to babies born to mothers who did not have hypertension after classifying them into the different categories of hypertension. You understand? And then according to gestational age. So they were like so to speak, the study group, which were those who were born to mothers who had hypertension. And then there was a control group, which were those born to mothers who did not have hypertension, and then compared them. And this was a snapshot study. At once, all blood pressures were checked at a particular time. So if we're checking, let's say we're checking a 33-week-old child born to a hypertensive mother, you also have to check a 33-week-old child born to a non-hypertensive mother, something like that.
It is still a snapshot now.
It's a snapshot, but you're comparing two groups. Like it's almost like it was a bit of it was a bit difficult to say, are these cases and controls, or is it a cross-sectional study, which we eventually arrive at the fact that it's an analytical cross-sectional study, because you're not assessing a disease in the child per se. You are assessing what the effects the mother's blood pressure has on the neonatal blood pressure. So let's say now
it is still a comparative cross-sectional study.
Okay. So does that mean does that mean it's not analytical?
It's a descriptive study.
Okay.
Because there is no time variable. You did not follow them over any particular time, did you?
No, sir. Or just a snap one time.
It's one time. It is not different from the example I gave, measuring in the rural. And so one group has this condition, the other group has another condition. So the only thing there, it will still generate hypothesis, because at the end of the day, you want to say that those maybe blood pressure of children born to hypertensive mothers are, because you compared it with the other one. Your comparison is valid, no doubt, right? But at the same time, it is not conclusive, because you have not exhausted, you didn't use a higher method of study, a higher study design, for instance, to do it, like in an experiment, So that is why it's still cross-sectional in a way. Still cross-sectional, because it's snapshot. You measure the blood pressure. You can't, you have concluded that those blood pressure who born to mothers are like children born to mothers. Maybe let's assume that the conclusion is that blood pressure of children born to mothers with hypertension is higher compared to the other group, right? Fine. That's a comparative study. That's a comparative cross-sectional study. It's a comparative cross-sectional study. It's not, although you see, the issue of analytical study is different. Many people say analytical study is because of the robust analysis involved. You are going further, apart from the bivariate analysis you are doing, you just cross tabulation. You are going on to carry out and do multivariate regression, so that you can eliminate confounders and all that and make it clean, and therefore it's analytical. So these are people's opinion. I don't think that is typical analytical. Analytical study, you follow two groups with conditions, without condition, over time, and see if they develop hypertension, right? So those are the things.
Okay, Prof. Thank you, sir.
Yeah. So for me, this example you gave for me is a comparative cross-sectional study. Please, let's go one after the Roslyn Amarachi.
So, sorry, sir. In other words, a comparative cross-sectional study is still a descriptive study.
Yes.
Okay. Thank you, sir.
I think my own school of thought says it's still a descriptive study. So you see what happens. Let's see. You see what some people do now. That cross-sectional study, if it is descriptive, right? If it is without a comparison, they put it under descriptive study. And once a comparison takes place, they put it under analytical study, right?
Yes, sir.
My argument here is that what makes it a descriptive study in the first place is the snapshot nature of that study, of which it does not give any temporal sequence about exposure or outcome, what led to what, because it's a snapshot. You compare two snapshots, and that is why I feel it remains descriptive. But some people say it's analytic. It is, in fact, maybe it's now you can even begin to see. If you look at older thought, you cannot see even that. You will not see it. Right. So that's it. That's why I strongly believe it is still cross-sectional, but cross-sectional comparative. It is not cross-sectional and it's not analytical. It's not analytical. In fact, if you're talking about analytical, every study, why even in cross-sectional studies, most cross-sectional studies, in fact, we could call cross-sectional studies analytical. Why? Because when we want to determine to the extent of predictors, right? When we do multivariate regression analysis, or we want to look at models, prediction models, We do that from cross-sectional studies. In that case, we call all cross-sectional studies analytical studies, simply because we did prediction, predictive modeling. So does that not make them analytical studies? Except we have to look a different way of overhaul this classification. You know, so that's my own argument, my own school of thought. All right, Omar, Amin.
Thank you, Prof.
Yeah. Muhammad, Umar. Unmute yourself and talk, please.
Okay, thank you, sir. All right, sir.
After which, I know for Ejiro, I know for Ejiro after Umar. Go ahead. Umar is like, our network is a bit horrible. That's there.
Hello, Prof. Good afternoon. Good evening, sir.
Good evening. Omar, yeah, we can't hear you. Your network is not good.
Good evening, sir.
Yeah, good evening. Go ahead.
My question is that, like me now, I'm in environmental health department. Most of our projects we look at assessing the health implication. Let's take, for instance, we're looking at this topic, assessing the health implication of poor environmental sanitation on the inhabitants of a particular community. Which study is best good for this research?
It's analytical study. It's either if you are looking at health implication, then you can follow people over time, or you look in the past, right? Okay. Yes, if you want to do it correctly. But you can also do a cross-sectional and do your analysis up to maybe multivariate regression. You know, so we just had that case, but ideally, you must follow. In that case, you follow two groups for that particular health implication you are looking for. Then you give the exposure and follow over time to see whether those health implications will develop or not.
Okay, so we cannot use descriptive.
That I said you can, but descriptive cannot prove it completely.
Okay. Okay.
Yes.
Okay.
Okay, sorry, sir. Please let me just ask this. Yeah, as she's asking her own in the same line. Okay. Prof, can you hear me?
I don't like when people are badging it. Why can't you wait? Am I leaving? Okay, ask now. Don't be in a hurry.
Please, I'm sorry for this. Let me just ask this question.
Go ahead. Ask.
Okay, so there is this research that was carried out about infrastructure on water distribution, municipal water distribution, and its impact on public health. So they started the study with collecting previous data. They want to know what is the impact of the state of the infrastructure, water infrastructure, and how it's affecting the health of the particular community that is being observed in. So they went in and they started collecting data from the hospital, but at the same time, they were also analyzing water from different sources like rivers, wells, borehole, and so when all these things were done right now, so while I was reading, I got a little bit confused because I didn't understand what exactly their study design was. I don't know if you understand what I'm talking about, sir.
They are looking at Gavin. A hold back from someone. What is that now? Please, if you are not asking a question, can you mute yourself? Kindly mute yourself when you want to ask a question. Oh God. Mute yourself if you are not asking a question. When you want to ask a question, then you're mute. Is that difficult to do? All right. Now, the person who asked the question, they want to look at the impact of water infrastructure and
Yes.
what is it, the impact? What do you expect? Well, we'll say it again. Before you look for the impact of that water infrastructure, which means the water infrastructure would have been there and the people are using it. Is it not? Hello?
Yes, people are using it, but it's not constantly available.
Okay, look at
Hello?
the way he's doing. Okay, hold on. Let me explain so that you understand well. If you want to actually look for impact of something or the effect or impact, as I started to explain earlier on, before you use the impact, the word impact, you must have that exposure would have been for a long time. If the exposure is not for a very long time, you look for effect. Because they mean different. These words are not just English words, they are technical terms. All right. If maybe you come in a place, before you install those water infrastructure, you make a baseline study before you install those water infrastructure. And after some years, you come and repeat that study and you compare the result at baseline and the result after the use of those infrastructure, water infrastructure, after about say 5 years. Then you can see a difference. And whatever the difference you see, you might now attribute that difference to the effect or impact of that water infrastructure. Otherwise, that is one method. There are many ways you can conduct a study. That is why at times when you're examining somebody, you can say, okay, which other way can you do it? You can compare the place you install water infrastructure and a similar environment where you did not install water infrastructure. And you see a difference in the two. So it depends on how this design. If maybe it is something from time to time, you say it's not constant. If it's not constant, it's difficult to prove. Who are these morons on this place? Eh? Who are these now?
I'll mute everybody now.
Simple instruction, mute yourself. When I call you, want you unmute yourself. Is that difficult to do? Please, okay. The person who was asking that question, go and explain again. Let's see if I'm understanding it very well and make it clearer for me.
Okay, now, can you hear me, sir?
Yes, I can.
Okay, so in the research, they are trying to assess the impact of bad infrastructure. So over the years, there was like a money. This is a real life scenario. There was money that was given for a project through the e-wash program for rebuilding of the water infrastructure in the state. Okay. So, but over a period of time, the infrastructure has been broken down in terms of their piping and the water distribution system, and because there was no maintenance done over a long period of time. Every time there is a distribution of water, there is a whole lot of loss in it. So they now started doing the research paper that, okay, let's look at the impact of some of these issues, like the infrastructure and the effect that it has on the people. And now the public health effect is what they are looking at. So in the process, they went to go and look at, okay, how many cases of waterborne diseases do we have in the hospitals within the capital of the state where this research was being done? 2, they also went to go and collect resources, like looking at data from the municipal water distribution company in the state. And then they also went to go and collect data in terms of knowing where is their distribution line reaching? Who are those that they are distributing to? Since they say that the distribution is going to everybody, who exactly is this water getting to? Okay, the people that you're not getting to, are they getting their water from borehole, well water, or running rivers, like flowing rivers, sir? So I'm trying to understand, in this particular situation now, what was exactly their study design? What would be the best study design for them to use in this particular situation? Because I feel like they are trying to do a whole lot, but I'm not yet sure of what they are trying to achieve.
Yeah, it is also confusing to me because the design appear to be all over the place.
Yes.
And if there are broken down facilities, so to some extent that's providing desirable effects, and to some other extent, it is not, and they are going to health facilities to see data maybe about waterborne diseases. It would have been nice to see if maybe before the commencement of data, they did a baseline, or when they are doing that health facility assessment of whether they are looking at comparing records before installation of those water infrastructure and records now. It's good to understand that detail, because if maybe they are comparing the health records in that area before those infrastructure was installed, and now they can see a difference, they can begin to say, yeah, that's the impact. But if you don't know exactly what they are doing, you just say they are collecting data, it's difficult to judge. It is possible they are collecting old, assuming is the infrastructure they installed 2020, right? Maybe they are looking, if they have data, they're looking at data in the as at 2019, 2020, and comparing it with data they have now, and see the difference. If a difference, particularly if it's water related, if maybe they have less of water related problems now, they can begin to infer that those water infrastructure installed made some improvement, even though they were broken down here and here. But overall, there was some improvement. That's the way I'm thinking. I might be wrong. I don't know.
Okay, thank you. Thank you very much, sir.
All right.
Thank you very much. I appreciate it.
Okay. Abubakar, Nairu.
Yes, sir. Good evening, sir. Thank you for the presentation.
Thank
So
you.
my question is regarding case control.
Yes.
You made mention that it's retrospective in nature. So I just
Yes.
wanted to know if it can also be prospective, like.
No. No.
Okay.
Case control is retrospective in nature. What can be both prospective and retrospective in nature is cohort studies. That is why the one that is prospective is called prospective cohort, and the one that is retrospective is called historical cohort. That is that. But okay, let me explain. Well, don't worry, I'm not teaching you cohort. Tomorrow I will teach you both so that.
All right, thank you, sir. Thank you.
Yes, you can see the difference. Princess Nkemka.
Good evening, sir.
Good evening.
Sir, I have two questions.
Go ahead.
The first one is, as a new researcher, because I'm still trying to understand this study design, as a new researcher, how do I match my research topic to the correct design, study design?
Oh.
That's the first one. The second one is, maybe when you answer the first one, I will know if it is possible for both for more than one study design to be used for the same research topic?
Yeah, yes. Okay, that's a very valid question, good question, because that's what a lot of people find very difficult, to know the appropriate study design on their topic. If you're an experienced person, actually, once you mention the topic, the study design is looking at you. But for a young researcher, or we'll call it early career researcher, it appears a bit difficult for you, right? But follow that classification that at the inception, if maybe, it depends on what you want to prove and this maybe at this early stage, your supervisor who is more experienced can help, because it's more difficult for you to figure it out. If you are going to have a control group, but before you have a control group, you will even know what, if that's even deeper, you will know whether the type of study design to use. If maybe, as I said, if maybe what you are going to do is to describe the people involved, the magnitude of the problem involved, the area that is involved, then assuming you want to do the prevalence of diabetes among a particular population, or prevalence of hypertension, once you are doing those prevalence type of this on knowledge, attitude, and practice, know that it is cross-sectional, descriptive cross-sectional, right? Maybe you want to compare what happens in among in-school adolescents and out-of-school adolescents. You want to see the difference, is comparative, is cross-sectional, comparative study. But if maybe you want to know why this occurs, or how, to what extent, then you are going to do into analytical, because that's where we begin to see relative risk and risk meaning odds ratio. So for now, this is something you will learn with time. I will encourage everybody. I've given you some books. I believe most of these things are written in those books. I gave you some. I can give you more. Read them. Slides is brevity. Read these things, you can understand more. They will give you more clearer pictures, more examples, and make you understand it more. Right? Then you ask questions. It's research has 6 points, 6 credit units. It's difficult. It's the most difficult thing you're about to do. Is research. It's the most difficult. And the annoying thing is that most of you hand it over to contractors, and even the contractors don't know it. So when the assessor is asking a question, we find that he's asking the wrong person the question, because people think that they just come and submit this thing that is done. No, it's not like that. You will explain everything. So it's best, in your best interest, to begin to read it, because at times some of you want to go higher. I was discussing with one of my PhD students. She's in Nevada. She was a person that delayed my this thing. She even, I'm going to speak with her. She said she'll call me about 10 p.m. because she has issues she wants to discuss with me. She said, okay, let me leave you, let you go and do your lecture. I will call back. Right? Now, she said she read in a fake Facebook, somebody said, that the PhD and all these things they do in Nigeria is point and kill. That's the yabbing. It has started. And to a very large extent, it's true. I can't defend the system because I'm very deeply involved and I know the rubbish that is going on. And now, as her, how is her own system? Like she's saying, she's preparing for her what is it? Is this thing she called it, exam, before This old age make you forget certain things, so you just want to remember.
5 hours, sir.
You know.
5 hours, sir.
Sorry?
5 hours, sir.
Not
Viva.
Viva. You are going to do both Viva and the exam. When, for instance, you are doing that first year, you do your didactic lecture or research methods and all that. That's a rate limiting step. You know, now if you are doing PhD, for that level, you are a PhD student. You need to pass that exam to now continue to do, and you now become a PhD candidate. You know? Yeah. Maybe if I remember when I speak, I will listen.
Comprehensive exam.
It's called what?
Qualifying for comprehensive exam.
It's a qualifying exam, actually. It's a qualifying. It is after that exam, you can now, you know, defend your research and you proceed. If you are not successful in that exam, you can leave. That's what they do. But in Nigeria, here is all commerce. So even people who can't speak English, everybody want to do PhD. They know themselves that they can't pull this through. They know. But because of the wishy-washy nature we do things, everybody does. So that you see somebody, a master's degree student, he doesn't have the basic knowledge of research. And is the first to pick up a PhD form and begin to jones about in the PhD. I have so many of them, even in our school. I just feel like chasing all of them away. Because you just come to trivialize what we are doing. You see me taking my time to explain this. It's not, many people will teach you, will not understand anything out of it. I try to break it down as much as possible, you know, so that people can appreciate it and know. Because after this level, that is the only thing that is required for advancement of science. So what do people do? They provide money to one illiterate. They do data analysis and go and bring certain standard deviation, agree. Standard deviation, agree. And we're looking at them. Where are these people coming from? You know? At the point, okay, you bring those your contractors. Let us teach them. Maybe since you have surrendered, let's teach them and see whether they will understand and do the correct thing. But know that you don't own the work. The ignorance continues with you. You know, so that these are some of the things people do in the name of shortcut and, you know, bastardize everything, including education. Including education. You know, just because we have some decadence in our in the country has permeated every aspect of our national life. It's not only politicians, excuse me. It's not. Politicians are just one. It's not only judiciary. It's everywhere. When they come to a hospital, they expect the doctors to behave like reverend fathers and reverend sisters. No, they come from that same society. You come from a university, you expect those lecturers to behave. In fact, some of them behave like touts too, because that it has permeated every society. You see somebody who was caught forging degree result, forging everything, and when he's no show of remorse because the system is so porous. In fact, he has the effrontery to contest for governorship because the society is wrecked. And it's not only politicians that wrecked it, though they helped it, because leadership is very important. If leadership was doing what is right, even the fear of that will enter some people not to want to do. That's why people say, go to court, I will do it, nothing will happen. And nothing will happen. That is what we are seeing in education. That's what we're seeing. People just come here believing that the system is porous, they just scrap through and have qualifications they cannot defend. So that's it. And when they have PhD officers, they appoint them lecturers. So what are they teaching? And that's how we begin to rubbish our education. Rubbish our education. The standards are falling. And the way it's falling, I'm afraid. All right. Princess, have you asked your question? Okay, if you have.
Yes, I have.
Yes, okay. Then the other one is what I can't Maputo. Maputo. Please pardon my pronunciation.
Bro, good evening, sir.
Good evening.
Sorry, you called me earlier. I wanted to talk and someone else interjected, so I kept quiet.
Okay.
Right.
Go
So
on.
my question is based on ethical. You mentioned something about cross-sectional studies that assesses knowledge, attitude, and practice. And my question is, does this kind of research really need ethical approval, or you can do it without obtaining ethical approval?
Every research needs ethical approval.
Right.
Ethical approval. Every research needs ethical approval because there are things including like informed consent, coercion, voluntarism. People should answer to your question voluntarily, and they might wish to discontinue whenever they want to. Assuming you're asking person question, I beg, I'm late, I'm not doing again. You don't have a right to force the person to continue. So that is why you need, it's not only when you are doing human experiment, right? Like our university, everything must pass through ethics committee, research ethics committee. It's mandatory.
Right.
Yeah. All right, Emeka Wanko, since the other Maputo or whatever don't want to say, go ahead, Emeka.
Okay. Thank you very much, Prof. My question is a simple one. In estimated relative risk,
yes.
When the value is 1, it means that there is no association.
Yes.
Then,
exactly.
when it is more than 1, it shows association or causality,
yes.
right?
Not exactly causality, association. Put it association.
Association, okay.
Yes.
Then, does the estimated relative risk have a particular highest value, or does it just go on and on?
It goes on and on. The number of times, maybe it's 1,000 times more likely to, it's because it's number. You mentioned causality. What we know in theory that if that estimated relative risk becomes high, 4 times, 5 times, then we can begin to infer causality. We begin to a very strong association. We begin to say yes, it's most likely to be causal. That relationship, that association is likely to be causal because that risk ratio is very high. Okay, that's how we interpret it. Yes.
Thank you, sir.
Yeah, you're welcome. San Ofem Okon.
Yes, sir.
Yeah, good evening.
Okay. This is the angle I'm coming from. I'm not a clinician.
Your network, I'm not clear with your this in the network is their voice is muffling. Can you change your position?
I'm saying that this is the angle. Maybe the of my public health is in health information or environmental that is not directly clinical. And I choose to carry out a research on malaria, and I intend doing it interventional. So the question is about how will I do it, and what exactly will I do to make my studies interventional, since interventional studies have more credibility and more valid point than other studies.
Until you tell me what you want to do, you have not said much. My study interventional, I have not know what is the study now. What do you want to do? You have not said.
Okay, this is what I intend to study pregnant women, the effect of malaria on pregnant women, and I want to intervene. So I'm saying that what exactly would I do? I just need an insight on what to do to make.
See, most times you also go and do literature review. You have to do a lot of literature review. Look at what people have done on that. The effect of malaria on pregnant women, right? So maybe if you are looking at effect of this thing, it's not on pregnant, maybe you're looking at pregnancy outcome. So you first and foremost, for every research, literature review is very important. The person who was making that yabbing on Facebook say, imagine a PhD candidate in Nigeria cannot even know how to identify research gaps. That's quite insulting, but she said the truth anyway. Make her no vex too much because that's the truth. Most do not know. And that's how we've been shouting and people are not ready. Although I will also agree when it comes to research, it's a little bit more difficult. Why is it more difficult? You can't see most of the things in books. You can't. Research is by participation. Understanding is by participation. When we are doing reviews, don't, for instance, you present your own work, you off your mic. That is rubbish. You are not learning. Once it's your turn, present and stay put and listen. As you are listening, others' corrections are being made. You are learning what to do right and what not to do right. You are learning what is wrong and what is right.
If you know the extension you are trying to reach, please dial it now. For a health business and aquatic place near you, there's 1. For childcare and daycare, 2. For enterprise and newcomer services.
Who is the person doing this one with us?
With us by visiting our website at YMCA.
Precious Umachi. Okay, let me just remove you, maybe, so that we'll get peace. Where is the man who was
thank you very much, bro.
Unmute yourself again. Unmute yourself, Sanya Okon. Unmute yourself and continue.
Okay.
So,
in terms of such study, if we are basically doing it, and I say I want
doing that effect,
to be interventional, which means we need
both
to do something.
clinical. That effect, that one is very clinical. It's not environmental, because you are looking at an effect on pregnancy. Pregnancy, we put is not an effect on pregnant women. It's mostly on pregnancy outcome. Maybe whether women who suffered bouts of malaria delivered earlier than they should, or whether maybe birth weight was lower, or whatever, because or maybe they had asphyxia and all that. So it's more clinical, very clinical. It's not environmental the way you are talking. If you want to do malaria that is interventional and that is environmental, since you are from environment, then you can do effect of larvicidin, and like that. Look if larvicidin can reduce incidence of malaria and all that. So those ones can be more of environmental than the other one. That one is even clinical. Yes.
I also want to see doing that. Are we necessarily going to carry out tests on them and also maybe put them under medications?
This thing that is breaking is not helping me, because when one word is missing, I begin to struggle to connect what you are saying.
Okay, let me repeat myself. I'm saying that studies, are we to carry out lab tests on them and also place them under medications? But I'm also careful since they're vulnerable groups.
Now, You have to carry out now to know their malaria status, whether they have malaria or not. Otherwise, how will you know? You know, you will first of all see, as I said, go and read around this topic. Go to guide you more. Go and read around it. Research requires a lot of reading. Go and read around it. You get more information. Go and read around it. Then it will help you refine. Go and read around it. You see what people have done, and it will assist you in refining it. Okay, that's the best way to go about it. That's the best way to go about it. Charles Ebuka, then Dr. Smiles, and then Egbe Matthew.
Okay. Good evening, sir. Please, you spoke about sending some textbook to us. I've gone through the file that was sent by the course rep. I'm yet to see any textbook. I don't know if you can possibly resend from your own end. Thank you very much.
Did you ask him?
Yeah, I sent him a message earlier.
Who did you find boy?
No, the other course rep from the one for public health.
Okay, maybe I sent it to Fine Boy. Okay, I don't know that person now, so maybe or what's his name? But I'm confused with him. What's the name of that person?
Let me sorry, I just want to confirm his name. I'll get back.
Daniel, sir.
Yes, sir. Thank you.
If it is Chukwunonso, I sent to, except I will resend. I did. Maybe you didn't collect it that time. No, I did.
Okay.
I did. Yeah.
Where do you Prof?
Charles Ebuka.
Sir.
Go ahead now. It was the person that spoke. Okay, Dr. Smiles. Please, it's 9 o'clock. Let's get out of here. I am tired. I need to rest. Please.
Good evening, Prof.
Let's after this, just one more question. I'm okay. I'm done.
Good evening, Prof.
Yeah, I can't be working from 9 a.m. to 9 p.m. Please go ahead, madam. 2 minutes, please. Please.
All right, Prof. Prof, I just 2 questions, sir. So one is I wanted to know what your opinion is. There cross-sectional analytical study. Can we have that study? I know you said you do not, the question somebody asked earlier, you said that is actually a description. I also know that some literatures also talk about sectional analytical. So I wanted to know what your opinion is. Do you think we can have a cross-sectional study that is analytical in nature?
Yes, now that's the question, listen, cross-sectional can be analytical. And what makes it analytical is the robustness of analysis carried out when you are doing multivariate regression analysis. Maybe you are doing predictive modeling and all that. Said all that. That's when cross-sectional is analytical, right? That's when you say cross-sectional, because why is it so? When you are doing that level of robust analysis, you are eliminating confounders mainly. That is why you see, it's not that cross-sectional analytical studies are not, but my quarrel with it is that every descriptive study, once you go deep into analysis, it becomes cross-sectional, it becomes analytical. So I don't see it as something special. No. It's just like if you watch literature these days, you see people begin to hype mixed method study. mixed method design, but mixed method is not a study design. I stand to be corrected. Mixed method is just a data collection procedure, both qualitative and quantitative. You know, if you are studying, looking at study design, you will never see mixed method as one study design. But when you want to depending on the nature of your study that has things to do with human behavior, for instance, and you note that you have noted that when you are doing only quantitative aspect, you design your questionnaire, you ask the questions, you provided the answers, and you're giving people limited options to choose one of the answers, for instance. You are not giving them sufficient avenue to get to know in depth why they do what they do. So in that case, if you now decide to do so, you design a mixed method. Okay. Now, either you use focus group discussion or you use in-depth interviews or key informant interviews to understand deeper, which you cannot easily understand, have opportunity to do so with the questionnaire. Right? That is just the mixed method. So you are having deeper understanding of what is happening, particularly with studies that have to do with human behavior, maybe drug use or, contraceptive use and things like that. Want to understand certain things. Then that's why it is. It's not that cross-sectional analytical is there, but at the same time, they are descriptive studies.
Okay, sir.
Cross-sectional studies are descriptive studies because they are snapshot studies. So many times, okay, let me tell you one secret. Many times when it comes to this thing, in order not to appear to have done a descriptive study, people just remove that descriptive, because when you write descriptive, it appears to demean the study. You just say cross-sectional analytical, as if there's one big thing. Not like it's descriptive study. Because when you write descriptive, it's like it's rated low. But cross-section, because it's a snapshot, it's a cross-section. If it's not a snapshot, why is it called cross-sectional? It's cross-sectional. So what we do, particularly at higher level, PhD level, when people come with cross-sectional, even though we discourage it because of evidence is limited. We say, okay, in worst case scenario, let's make it a mixed method, a cross-sectional, with a mixed method approach in collecting. So with the mixed method, try to deepen the research by that. It's a glorified cross-section.
Thank you so much, Prof. That's clear enough. And Prof, lastly, you said case control studies. You said they're retrospective in nature. So in an instance where the case and the control if those data are collected instantly from the patient, say in a hypertensive clinic, you want to compare the effect of, say, an antihypertensive drug or the effect of hypertension on, let's say, the kidney, using one of the renal biomarkers. So you collect, you get the case and the control instantly from the clinic. You're not looking from the history. You're getting them instantly. You're getting those data for both case and control and analyzing them. Can that be a prospective or a retrospective case control?
Is there any period of any longitudinal aspect, period of follow? You are looking at, paint that scenario of the study again. Let me just.
Okay, so I say, for instance, in clinic, you want to get the effect of hypertension on, let's say, the kidney, effect of hypertension on the kidney, and you want to use biomarkers, to do that. So you get the case, and then you get the control, and then these patients, you're getting them instantly. You're not looking at history, so you're
patients, as new patients are coming in the cardio clinic, you're recruiting studies, both as case and as control. That study, in that you're not looking at you're not going to the previous history, looking at past patients, you're looking at them from when you catch them in the clinic. Is that a retrospective or a prospective?
Okay, let me understand who you classify as cases. Cases are those who have kidney problems or hypertension.
Yeah, so cases are both case and control are hypertensive patients. Both are hypertensive. So, but what you want is those of them that eventually have coexisting renal issues. Of course, I know that hypertension does not explain all renal issues, but just this my scenario. Say you want to get those hypertensive who also have coexisting renal issues. Among the two, so hypertension is the yardstick for recruiting both. But then the case now, those of them that have coexisting renal, you want to compare them to those of them that eventually don't have renal. But then you're getting them on the go. You're not getting them from case note or something. You're not.
I know. Okay, in that case, what is your outcome variable? What are you comparing them for? What are you looking at comparing? What as outcome?
Yeah, so
comparing them to have what?
To have renal issues, which how many of these hypertensive patients would eventually come down? How many of them coexist with renal issues? Now I know that this sounds like a cohort study because you have to follow them into the future, but I'm saying you're not following them into the future. You're recruiting them instantly. You're getting them at that point in time and classifying them hypertension. This one have renal issues, this one don't have renal issues, and then you analyze the data to see what affects hypertension, if it is related to hypertension or not, in most cases.
Yeah, that's why, in fact, the study has a lot of confounders, because both of them, one group has hypertension and renal issue, the other group just hypertension without renal issue. And you recruited both at the same time, right? You recruited both at the same time, maybe consecutive recruitment in the clinic as they appeared. Then you compared both of them, maybe look at socio-demographic characteristics and all those. It's a cross-sectional comparative study. It's a cross-sectional comparative study, yes.
But Prof, can it be set to the retrospective, or we shouldn't look at it from that angle? I know my scenario is the first scenario.
You are not looking at it. If maybe you are looking prospective, for instance, at prospective, right, you are following them for over a period of time. In prospective, one should have the factor of exposure, the other one does not have. But if maybe now, these two, maybe one with hypertension, with renal issue, the other one without renal issue, and you are now following them over maybe say the next 3, 4, 5 years, and you want to see maybe certain outcome from each of them, then that would be a perspective, but you have to clearly define the outcomes you want to look at. But when you see renal issue, because most of them now has to maybe renal issue, you have to categorize them more. So we want to see maybe you have to categorize the disease and clearly define which outcomes. In that case, you are making it cohort, following them, but then they must be similar in terms of characteristics. If the males, socioeconomic values, education, because all of those things have a way of affecting health. People who are more educated are more likely to comply with medication compared to those who are less educated, who just, somebody will tell them, I know one concussion, if you just add bitter leaf and use it, they will quickly, because one, income also, they are avoiding to spend money, so they want to some other cheapest remedy along the road. So those things, that's why if you are comparing them, they must match. Otherwise, these small things can destroy the study. It can affect the outcomes. Yes. So it's that one.
Thank you. Thank you, Prof. Thank you very much.
All right, gentlemen, I think we'll end it here. Any other questions you have tomorrow? I'm done. All right, thank you. See you tomorrow.